This is Dr. Benjamin Fergus, and I'm happy to present Grip Performance Upper with a focus on baseball. A little bit about my background. I'm a chiropractor practicing in Evanston, Illinois. Our practice is just north of Chicago. It's called Cornerstone Health. Within this practice, we also have a fitness program called Foundational Fitness. In this program, we discharge our patients into fitness in order to build durability and reduce future injuries. In piecing together all of my clinical influences, we've developed a GRIP approach, which stands for Global Rehabilitation and Injury Prevention. GRIP approach began as an organization of currently available programs and resources, and out of that work has developed our unique approach to assessment, rehabilitation, and tissue therapy. The biggest focus for me is in the evaluative process through GRIP approach. My primary clinical focus is on chronic and complex presentations. That makes up about 90% of my daily clinical load. This is typically persistent pain, unresolved limitations, sometimes comorbidities, especially with autoimmune conditions, and failure to respond to previous medical interventions. Another 10% of my practice focuses on biomechanics and performance. This is typically a thorough biomechanical evaluation of athletes, either elective athletes or at the collegiate or professional levels. And we then work to restore limited movements or activities and develop a performance program that includes injury prevention. We also consult with several teams and providers for various levels of athletes. For me, this all began when I set out to learn and influence healthcare with an engineering mindset. Essentially, I need to take it all apart, understand everything, and put it back together, hopefully in a way that makes it work better. To do this, I needed to read everything, identify overlap, and then find a way to both classify and test these hypotheses. The biggest influences on GRIP approach have been Pavel Kolaj's dynamic neuromuscular stabilization, the excellent work by the International Fascia Research Congress, particularly the works of the Stecco family, Vleeming and Schleep, and the textbooks by Leon Scheitau. Lorimer Mosley and David Butler's Explain Pain, I think, is a must-read for anybody that deals with musculoskeletal injuries and pain. And the very detailed biomechanics books from Tom Michaud that focus on the gait cycle, both of the lower extremity and the upper extremity, are very good resources. More recently, I've been learning from Michael Shacklock in his clinical neurodynamics, and in this baseball-specific course, we will certainly screen through the upper extremity neurodynamics tests, as they are a common driver of discomfort in the upper extremity and neck. We also draw heavily from empirical movement sources such as martial arts, yoga, running, and various sports. GRIP approach is all about dissecting movement. We use our overlapping knowledge of all these current methods to then drive meaningful change. As musculoskeletal providers, we're very accustomed to movement evaluation, whether that's palpating a spinal joint in 3 planes of movement, palpating an injured joint such as patellofemoral complex, or palpating soft tissue changes in an area of an injury. And we also have advanced training in looking at movement screens, whether they are broad or focused. So what I'm proposing is not a large departure from these movement evaluations that we're accustomed to. But I propose that we evaluate controlled movement in all planes and at each involved joint complex. This is different than determining total joint range of motion in all planes during a single test. We have divided each regional anatomy into tests that address a single plane of motion at a time. And in doing so, we can quickly unlock what's limiting a more complete or full movement locally and globally. The way this solution works is to first identify 3 to 5 movements or tasks that your client is having difficulty with. In the athletic population, this may be a specific type of pitch, the type of swing setup that they're using, or the way they run to the plate. We're going to identify what they're struggling with, what doesn't feel quite right, or perhaps where they're feeling weak or having discomfort. When we look at these 3 to 5 movements that are identifying their problem, our first job is to think about these established neutral zones and neutral movements that seem to reliably be consistent across many populations. When I watch somebody squat, walk, and swing the golf club, I'm going to determine if their posture or their control consistently breaks down in the same areas. A good example of this might be a client that comes in with some right-sided leg or back pain. When I watch them go into a deep squat, they have a fairly pronounced shift towards the right of their pelvis. When I watch them walk, they may have limited hip extension on that right side, including perhaps an early heel rise or a weaker toe off. And when they swing the club, I may see over rotation in the mid or lower back. All of these movement issues that we're identifying will lead us to an evaluation of the hip joint in all 3 planes of movement at a minimum, as well as perhaps the low back or pelvis. As we then take these global movements that they're having issue with, we want to identify 5 to 7 tests that are based on specific planar movements at the involved joints that are consistently breaking down. Our tests are designed to highlight the movements, the articulations, and the tissues needed for normal human tasks. These are based on common developmental and adult movements, and they are not movement tricks or extremes. An example of a movement trick or an extreme may be if you're working with a contortionist or a circus performer, or in some cases a baseball pitcher, where they need to create movements with control that exceed the baseline movements that we all develop with. These might be extremes, but goal 1 is to make sure they have full control and full competency of the basic human movements. We then utilize treatment options that target specific deficits. We follow the studied healing principles, and we try to build a rehab plan that's very logical. Our system of evaluation with grip approach is called motor control grading. That's the overall system. That diagnostic approach powers grip approach, and the foundational test for us is the FROM test. That stands for functional range of motion. It's a movement test in a single plane of motion involving mostly a singular joint complex, and we're looking for movement breakdown or compensation before they get to the point of the prerequisites for normal human movement. Motor control grading as a diagnostic method is key for the pro or the Olympian, yet it is scalable to any level of ability and disability. And because of this, I can apply the same tests in my office focused on chronic and complex pain presentations as I use when I consult with athletes or teams. This sheet on the left is my evaluation form for grip approach. It's going to list the key regions that we're testing, as well as the movements in single plane that we test at each joint. Now, that's too many tests to run through in a single session with a single athlete. So our goal first is identifying consistent deficits across global movements, and then narrowing it down to which individual joint complexes we need to test. A simplified breakdown of motor control grading is to determine which specific joints are required in global movement, then test the passive and active range of motion for each involved joint plane involved, and then compare this to developmental and the ADL guidelines. When we have a deficit, we try to highlight which deficits are most key for their presentation. Typically, these deficits are asymmetrical, the deficit is greater than 10% off of our goal of ideal movement, and it's implicated in their clinical or performance presentation. When we have these key deficits, we then classify the findings to help us design a smart and efficient rehab plan. Motor control grading as a diagnostic method is comprehensive, it's been proven to be reliable, and it's built to be actionable, meaning each test will lead to the best avenues for treatment, and it highlights when further testing or imaging may be needed. The keys to long-term success with GRIP is to not start with the long shot, to not be fooled by the transient effects of an exercise, an injection, or a therapy, to design a rehab plan that is logical and can be followed by the client or athlete that you're working with, and it has goals that are focused on the individual's key deficits as well as the mechanism needed to change the tissues or the motor planning that's involved. In addition to this, it's important that we don't jump around. If you jump around, you're going to fall into the trap of paying more attention to transient effects than actually overcoming the key deficits involved. So we want to get the classification right, determine if the client responds in line with the known healing mechanism, dosing, and time, and if not, we're going to re-exam and send for appropriate diagnostic testing. Our big goals with GRIP approach are to restore controlled motion to any joint complex in each plane of movement. We then want to secure full motor output throughout the entire physiological range. We should be strong at each position in the entire range of motion. And very importantly, especially for our performance clients, we need to reduce the reliance on compensatory movements that diminish performance and drive injury. Now, our bodies are beautifully designed with lots of redundancies. If a movement is not complete and if a movement breaks down, we have a way to overcome it. We can pitch through adversity. We can swing through an injury. However, we do this via these redundant compensatory movements, and that's okay. That's a survival mechanism that makes us a durable, long-living organism. However, these compensatory movements often diminish our performance and are implicated in chronic and recurrent injury. So we want to have full motor output through the range of motion that's needed physiologically, and then if we have movement or performance goals that exceed the physiological norm, we need to work with extra focus on achieving and maintaining control of those movements that exceed the physiological range. Only in doing this do we reduce the compensatory movements and keep our athletes performing well and keeping them off the reserve for injury. So the big summary of GRIP is that we are meshing assessment, soft tissue, and rehab for clinical, or in this case, performance success. In this class, the Performance Upper Series, focused on baseball, we will not be employing soft tissue techniques. That is an advanced principle that we cover in detail in our clinical coursework. However, we will use a demonstration of our tissue techniques in this course. Your next step following this video is to run through a series of introductory videos. These act as the prerequisite lectures for the class, and they allow us to dive right into practical when we begin Saturday morning. I want you to pay close attention to the terms of neutral zone of reference, global reset strategy, and global performance exercise. When we go through those videos, you should have a basic working knowledge of what those terms mean in this system and what our goals are as we put our athletes and our patients through this assessment and utilize that data to build a very effective performance or rehab strategy. I look forward to seeing you at the course.